After hearing all this and the challenges ahead, I came to a thought. I've decided to retire. I wanted to announce it here tonight. With our three distinguished panelists, please come forward. So I'm going to open the bidding, if I may, with a question for our panelists, and then we're going to turn it over to you. They want to hear from you. They want to know what's on your minds, and you are our future. So thank you again for even taking the time to be here with us this evening. So gentlemen, I'll start with you, John, if I may. So studies, every week you read in a newspaper, New York Times or here or any journal, that studies have shown that once hospitals get involved in physician organizations, there's an increased cost to patient care. We had a situation recently where we bought a hematology-oncology group. One of the doctors gets interviewed by the New York Times and, of course, said all of the wrong things, for which I got called in on Monday. But the point of it is, that is the sense, that if infusion therapy was done in the office, now it's going to be done in the hospital. There's the different pricing levels, et cetera, and is this really going to help the patient? Could you give us your thoughts on that, please?
Yeah, I think what's going on in the environment, I think, that drives that, and as you said, Tom, there's data that supports it, is most healthcare systems are on two different curves. They're on two curves. So you've got, I always go back to the money, the alignment of incentives. And so if the incentives are aligned, hospitals and physicians working together can become more efficient, can do the right things, can move the procedures to outpatients, do things that make sense. We're also on a curve of fee for service. And so when you're aligning physicians with hospitals, there's that competing force. And so the fee for service environment drives that cost of care, because that's the way you're getting your money. I mean, I love what Bill said, but I'm going to totally challenge him that if Kaiser tomorrow was turned over to all fee-for-service, whether they would be the same, and whether they would have the same incentives, the same motivations, and the same direction in their care. You've got to follow the money. And that's what's going on in the healthcare system. We've got to change the reimbursement model, then we'll change behavior, then we can look like what Bill's doing.
Good. Well said. Thank you. Scott?
Yes, and Tom, great question, and I am familiar with the data, but there are also data and studies that have been published that when physicians affiliate with hospitals, that quality of care improves. And a study out of the Journal of General and Internal Medicine where they looked at preventive care indicators. How well are we keeping our patients healthy? How well are we treating their chronic disease? That the indicators, I think it was 8 out of 12, improved significantly when physicians affiliated with hospitals. Now, why is that? It's probably because the physicians had access to greater investment to create an infrastructure to close quality gaps. Now, using the same principles with the investment and infrastructure that could be used and has been successfully used to close quality gaps could also be used to close cost gaps or to improve clinical efficiency. And I think as we see increasing alignment, affiliation between hospitals and physicians, my hope and belief is that we will see the tremendous capabilities that hospitals can bring are used to improve clinical efficiencies and can be used to drive down costs.
Good. Thank you. Bill, if you would.
Sure. I almost thought John was trying to be controversial there, but I agree with him 100%. I think form follows function, and when you align the financial incentives, behavior follows. So I think that's actually right. The actual, probably the first blush, public blush at the answer to that question, again, IHA is publishing a total cost of care analysis that'll come out after the first of the year. And it's the first time where they've taken, again, provider organizations and mapped them against quadrants and said what you get is what you pay for, and who's going to be in the first quadrant with relatively low care and high quality and in the various stages. I think what, and I'll let Scott speak to it, I think what is certainly challenging as we live in Los Angeles and live in this state, in this country, is that there are hospitals that do extraordinary things. It could be California Medical Center and their inner city mission and caring for as a safety net facility, or White Memorial. It could be Cedars-Sinai and so many others who do medical education and training and research, and so many advanced, not only quaternary, but other things that are almost one of a kind in the country or in the world. And so there are funds there and dollars there that might get actually, from a data perspective, included in a cost-quality equation, and I don't know if that's actually fair.
So I'd like to turn it over to the audience. I have many more questions, but I want to make sure we give you a chance to be heard. Jack? Jack, microphone, please. Thank you.
Hi, I'm Jack Needleman. I'm chair of the Department of Health Policy and Management here at the School of Public Health. I was very taken by John's comment about the need for alignment of external incentives to get the right incentives internally. And as an economist, I absolutely believe that if you get the incentives right, the organizations will follow. However, as an organizational management person, I'm skeptical of that. So I'm wondering if you've all talked about alignment in your organizations, and you've talked at a very general level, by and large. And I'm just wondering if you can describe some of the very specific, important challenges you've had to achieving alignment in your organizations, and what concrete steps and actions and structures have enabled you to better achieve the alignment that you've talked about as central to what you're trying to do.
I think the actual playing it out, and if you're following the financial alignments, and so what we found over the years is there is a lot to be said for information and data and the correctness of the data, and I see physicians responding to what kind of quality, what they're really providing for populations. And I think if you begin, again, it's all the alignment of those incentives. If those incentives are moving in the right direction, and physicians are notoriously competitive and they want to always be at the top of the class, giving in that kind of information and what they're really doing and how they're managing their populations and what those outcomes look like are really, really important to physicians. And they begin to make really right decisions when you really load it on the quality side and the outcome side and make, the finances kind of come second. And so I think one of the keys is the report cards and the ability to have really sound information, both information about their performance around the population, around gaps in care at the point of care, so they know what the population needs, what needs to be delivered. I mean, I think that those are some of the tools. Ties a bit to what Bill was talking about, one of your major tenets around EHR. And again, that electronic connectivity, I think, becomes a very important tool at actually moving the organization in that direction and changing the culture and the behavior. So those are two of the big things, I think.
Yeah, no, I agree with John, and I think going back to why physicians became physicians, you need to bring information to them that if we're proposing an approach of care that will improve value of care, that there's evidence that'll lead to the best outcomes. You really need to engage the physicians in a discussion why this is good for patient care, why avoiding potentially harmful treatments or tests that will not provide benefit, why that's actually good for patient care. So I think it's really providing and having the discussion with physicians about the underlying scientific basis for whatever is being proposed to improve value and clinical efficiency, and why that's actually the best course of care for their individual patients. And then second, as I mentioned earlier, you need to make it easy, make the right thing to do, the easiest thing to do, and that's where you set up systems of care. So, for example, I talked about the frail elderly, and so having care management systems, based on the database that we have, we've noticed Mrs. Jones is at high risk for hospitalization. Would it be okay if we sent a nurse practitioner out to see her? Whether we did a fall assessment on her, maybe enrolled her in a fall prevention program, medication reconciliation in her home, so that really the work falls on the care provider who is best able to perform these tasks, and it does not fall upon the physician to remember that Mrs. Smith would benefit from these particular types of type of care at home, and that it's carried out, and then afterwards a communication letting the physician know, look, we saw Mrs. Smith, we enrolled her in a fall prevention program, her gait's steady now, and we're going to go follow up with her in a week. So making the right thing to do, the easiest thing to do that takes as little of the physician's time as possible if the time is not required to deliver that care.
Bill?
If I'm understanding the question, Jack, it's how you create alignment of a physician's behavior?
Yeah, and specifically, what kinds of, very concrete kinds of challenges have you had in creating that alignment, and what kinds of strategies and activities have enabled you to overcome the problems?
Yeah, again, I'll reference a couple of things. One is, in our world, my world, clearly is different and unique than these other gentlemen, in that there is this exclusivity. And so there is one formulary, there is one system of payment. The physicians are on salary with incentive plans. And so that consistency and that exclusivity of working with one health plan under one set of rules, I think also creates then a stability and a consistency. And so someone can build a career and learn the practice patterns and practice and be a physician in a very different environment where they may have risk or capitation for some book of their business and may have fee-for-service for others. I think that's a major element. I think there's also something, and it's best served under a premium or capitation arrangement, but I guess you could develop it under a fee-for-service, is who takes risk? Who takes risk? And so in Kaiser Permanente, do the hospitals have a margin? Does the health plan have a margin? Or how did the physician? And so there is a triad of negotiations every year. And so clearly it's like, oh, they must all get along and live happily ever after. Thank you. I see a lot of people saying, what are you talking about? You're absolutely right. Budget meetings are hell. You want how much? Are you kidding me? And it always starts out, okay, the physicians get X, and the program office gets Y, and the hospitals get what's left. It's a minus something. Okay. But in the truth, there is a very healthy dynamic tension of where we're going to invest. And is it in our people strategy? Is it in our capital structure? Is it in our IT? Is it in growth opportunities? And I think having that conversation year over year, having that trust in the relationship creates, I think, a behavior that says, let's put the money where it should be and do what's right. And so there's a lot of things that I think may be unique, but I think also are aspirational as these other groups try to form more of a integrated model.
Thank you.
The only other thing I wanted to add to that, because it's so pertinent to what Scott and Bill were saying, I don't want you to miss the point of team-based care. The fact that it's not just the physician, but it's the entire team that are delivering kind of this service, and that's really where we're headed and where we need to go. And so again, I think that's a really kind of a bottom line direction and tool that we all are moving in that'll make a difference.
Thank you. Please.
My name is Peter Freeman, and I work with the Philadelphia Medical Center. I was very interested in the graph that's up there about value-based care. There was a graph. One question excluding Kaiser. Over the past 18 months, we have seen a major consolidation in the insurance market. At what point do we provide too much value-driven medical care that it is more expensive to provide the care than we're being reimbursed because of lack of competition? Excuse me.
Take that first.
Yeah.
Okay.
Yeah, I mean, well, I think we're all kind of concerned about consolidation, and depending on what side of the aisle you sit on, from a provider side, you're concerned about the health plan consolidations, and then how do they drive down rates, and can we make it work, as those rates continue to be driven down. On the other side of the equation, even Peter Lee at the exchange had commented that he was more concerned about provider organizations, physicians and hospitals coming together and driving rates up, because they're the ones that really hold the card, because patients need care and they're going to have to go somewhere. So they're kind of competing forces, so to speak. I think that's a tough one, again, depending upon the reimbursement model. I know I sound like a broken record. But it kind of always comes back to what's the partnership or relationship with the payer and provider, and what are the alignment of incentives that make you work collectively so that you both win. Is that a capitation model? Is that a shared savings model where if you do save dollars, you get to share in that? Is that medical program models, you know, how we provide care and working collectively on models together? I mean, ultimately, the payers have to have a solid provider organization and something that's successful. They want that. So it's going to be a really interesting next, you know, few years. That's the crystal ball at the end. What does the future really hold between payers and provider organizations, in my opinion?
Yeah. No, I think it's an excellent question. You know, it's a valid concern. I think in addition to Kaiser, we shortly will have 3 health plans with each with revenues in excess of $100 billion. And what does that mean for reimbursement for providers? And so we will find out soon. But with that being said, I think there is some room for all of us as providers to reduce waste. So if whatever happens on the health plan side, some of which may be partially outside of our control, if you look at the Institute of Medicine report and the study in JAMA, that there may be up to 30% of healthcare is waste and 10% of healthcare is overtreatment. So while we're waiting to see whether these mergers go through and what it means for provider reimbursement, I think a lot of us need to have our heads down to do what we can to reduce the waste, which, if one believes the studies, will preserve the same level of quality of care or actually even improve quality of care.
Yeah.
You can go. Okay.
I have permission to speak? Watch this trend. How are the hospitals or the integrated networks pricing in narrow networks? Why are they suddenly giving 10, 15%, 20% discounts? And originally when the narrow networks or Covered California came out, there was a lot of people that said, no way, no how, and now they're all in. So I think at some point someone's going to look in the rearview mirror and say, what were we thinking? What were we thinking? Why does Sharp have a strategy in San Diego to take on any account at Kaiser Permanente between 100 and 250 lives and say, whatever it is, we'll beat it by 10%? Why does Vivity have that same strategy? Because we can do it. That's my point. For if it's 3%, 5%, 10% of your business, and here's the theme, actually, this is what I want to say. Please, if everyone could emulate the care and the quality and the access of Kaiser Permanente, that would be our dream, because that's what our communities deserve. And the thought that Kaiser Permanente is the bullseye, you've missed the point, I think. And so to go out and buy business to take it from Kaiser Permanente, we're going to do fine. Be smart in how you price and how you position, not just for next renewal, not just for open enrollment, but what are you going to do over the next 2 or 3 years and 5 years? And so think of your balance sheets, think of how you're going to position.
Please.
Adjunct faculty with Judge Hobbs Medicine in the Department of Genetics. And the question is really on component of Sharp's procedure and R&D part. And also the innovation initiatives Kaiser. That is, there's a lot of docs places. I mean, we've just gone through meaningful use and EHR adoption, and we know how much fun that's been for docs. You've got ICD-10 tomorrow, you've got ACOs, you've got the whole value-based trend in general. So my question is, what about those startup companies coming out of UCLA or MIT or incubators in Israel with the next generation of medical devices or imaging and the space or the capacity for applied R&D for the health systems, whether they're more community-oriented or academic medical center-oriented? How do you see just the absolute capacity of that and R&D capability for these organizations moving forward in light of all the other health system transformation?
Would you start, Scott?
Sure. And Richard, I want to make sure I understand. So you're talking about all of the new technologies, the investments that are being made, and how they may help facilitate value-driven care?
It's both facilitate, but with so much on the table today,
Yeah.
with all the transformation going on, are the docs still going to have time to participate in the clinical trials for the next generation of really transformational technologies, whether it's new non-invasive imaging or those kind of things?
Yeah. I think a few things there. First, we need, and Tom and I discuss this all of the time, as well as others from Cedars-Sinai, we need to do whatever we can to develop the systems of care so that doctors can be doctors, and whether it's team-based care, and they can focus on caring for each of their patients, and have as little burden as possible of doing tasks that may not require their attention, that the patient may not directly benefit from, but others on the care team could deliver and be equally effective. But the second part of what I think I heard, there's a tremendous investment in healthcare technology today, and a lot of money is being poured into startups, tremendous amount of money. A number of the startups are providing both products and services to improve the value of care. Many of the companies will fail or be bought, but some will be highly successful and produce new innovations that will enable us to deliver better care. So at Cedars-Sinai, we carefully evaluate many technologies and startups. There's a vetting process, what are the technology risks, what are the clinical risks, what are the business risks, and we actually have a venture fund with Memorial Care. I don't know if Memorial Care is here, that helps us with the evaluation process. It's called Summation Ventures, and we've been piloting some of the new technologies that we believe are most promising and can enable us to deliver better care. So, for example, in the patient engagement space, we have been doing work with some startups that we believe have very promising technologies. So we're very excited about what's out there. We think it's going to help redesign care. I think it's going to be good for patients, and we have a process underway to really evaluate all the technologies.
Another question, please?
That one's good for you.
I have one.
Hi, I'm Tony Schiff. I'm a healthcare lawyer. I teach health law here in the School of Public Health. One of the things that Tom pointed out, of course, is the tremendous amount of change. One particular trend that interested me is the fact that health systems are now beginning to form their own health plans. We've seen a significant increase in the number of Knox-Keene licenses being issued. Those of us that look at it from both sides try to note that operating health plans is a complicated matter. That said, at what financial size is the movement towards, or the decision to actually form a health plan and health system, at what financial size is that viable? Cedars is approximately a $3 billion a year entity. Sharp is at $3.5 billion, according to you, Doctor. At what point is this viable? We've watched some of us in the pages of the NYT or WSJ, the Highmark UPMC thing going on the East Coast. At what point is it viable for the health systems to actually form their own health plans?
I think the way that I would answer that question is that each organization actually has to kind of make their own decisions, but I don't know that it's the size of the organization, to be honest with you, whether it's 1 billion, 3 billion, or 6 billion. I think it's more a decision about what is your unique market and how are the current payers playing in that space, and what are your partnerships with those payers, and does it make sense to challenge that? There's a number of failed attempts of health plans to be started by rather large organizations, and it is not an easy undertaking, nor for the faint of heart. And to go in and think that you're going to win the Anthem and the Blue Shield and the Aetna contracts that have been out there, and the national contracts, is a big kind of leap. So I'm not sure it's the size of the organization as much as it is kind of the unique market. Where I've seen it be a little bit more successful, I guess the size would make a difference if you're kind of starting your own plan and you want to start with your own employees, and it may give you enough nidus to kind of get going and get your feet wet and move in the right direction. But that's the way I kind of dissect it. They're definitely not all jumping in. The partnerships with the current payers may be reasonable. On the other hand, I think for Sharp, our own health plan, I mean, we we like what Kaiser does. We like that alignment of the plan and the hospital and the physician organizations, and so we like what we're doing with that. And it brings back a lot of value and benefit, drives a lot. It's a not-for-profit plan, so it drives a lot of the cost and the return to investors out of the system, and a lot more dollars are returned to the care. So those are kinds of the pros and cons, I think.
And I agree completely with John. We don't think it's really size, but strategy. And so, for example, with us at Cedars-Sinai, we do not have a health plan, but we are a Vivity founder, member with, so we work with Anthem, our friends at UCLA, Sam and Patricia there, a number of other health systems, Memorial Care, Good Samaritan, PIH, Huntington Memorial, and Torrance Memorial. So we've created a commercial HMO product together, so that's our strategy today, and we're working very closely. How do we add value? Vivity. How do we improve our care management processes among all of the Vivity founders when a patient from, let's say, Huntington Memorial happens to go to Torrance Memorial? How do we exchange information? How do we do data analytics to identify gaps in cost of care and quality of care? And then, how do we improve patient experience and engage patients more effectively? So rather than, that's really our strategy at this time, to offer, more affordable care, working quite collaboratively in a new model with a health plan along with other provider systems.
So unfortunately, we're running low on time. Richard, I think you had your hand up for one last question, if you would, please.
Yes, Richard Sinico, I'm on the faculty here at the School of Public Health. You've all very clearly laid out how we are at the forefront of what is going to continue to be a tremendous amount of change in our delivery system. My question is, to what extent, and to your knowledge, how much of this information is currently being provided to those who are in training in medical school and in residencies? And because we're all, I think, on the same page about moving towards team-based care in schools of nursing, pharmacy, etc., is it happening at all?
I'll surprise everyone by going first, and I wish Dr. Chu were here. Probably still in the second or third inning, but Kaiser Permanente has every intention to launch its own medical school. And with that, it will embrace the population health, primary care attributes, and bring a lot of the disciplines of what the new healthcare model evolves into, and create a program that is highly practical, highly applicable, less didactic, with a lot of the lab learning, but a lot more of the experiential learning. And the plans are underway in the near future to begin to pull all the many facets of that together. So I think that's probably acknowledgement that in some pockets, and my colleagues can certainly reference it, there may be evidences of training and building the right workforce, physician force of the future. But at some point, we felt we had a responsibility to also put our money where our mouth is and invest in that.
Yeah, in a prior life, a prior career, I was actually in the academic arena. I was program director for family medicine residency and on faculty at the university. In those days, certainly there was no curriculum. There was nothing that kind of went in this direction. When I actually started at Sharp, we started a family medicine residency, and that was part of the reason to do it, and kind of we were a lot in managed care and kind of working in that direction. So again, I think it's like Bill said, it's kind of small pockets and in certain environments, but because healthcare is changing so much and so rapidly, and the things that we're talking about here today and what's being driven by the ACA and MACRA and other things, I mean, it's just got to trickle down, and it's got to start to go in that direction. There are some other new startup medical schools too that are completely devoting themselves in that direction. So it'll be interesting to see what happens there.
Last week I had the opportunity to be invited in to a lunch meeting of the first year and second year UCLA medical students, and they asked me to talk about innovation in healthcare, healthcare information and technology, new patient engagement strategies. What will future physician look like? Will they be selected based on their organic chemistry grades and scientific GPAs, or will it be about emotional IQ, along with intellectual abilities and procedural skills and ability to adapt to change and participate in teams? And I left excited, encouraged, and optimistic, because part of it was presentation, part of it was back and forth discussion with the medical students. And they said in their curriculum, they were exposed to what the future of medicine was going to look like. They were not discouraged by it, but genuinely excited about it. And they understood they were going to practice in teams. They understood that future generations of physicians aren't going to be selected based on what they can memorize, but how they can access relevant information in real time based on their listening skills. So I ended up, right afterwards I called my wife and I said, wow, I am so excited about the future of medicine, because all of the medical students, they get exactly what needs to be done to deliver the best possible care to our community.
That's encouraging. Yeah. You had a
You know,
fun day.
when
I did, like a field trip.
Yeah, I did. It was a field trip.
Nice.
I grew up in a home which I always felt made me the right person for this job, where the doctor was revered. I grew up in a home where, when, in those days we had one phone line. When the doctor would call the house, no one was allowed to go near the phone because the doctor might call. And then my mother would call everyone she ever met and told them the doctor called. I can't tell you what a pleasure it is to work with doctors. Not always easy, of course, but they do God's work, and we have pulled them into these models. They're autonomous by their very nature, and we've herded them. And it's tough, and it's a different world. And as one of the folks in the audience said, now comes meaningful use and ICD-10 and everything else. It's just not going to be easy. So we need to cherish them, and we need to love them. When I went to school, the smartest kids in the class all went to medical school. And I asked my daughters where their friends are, because none of them went to medical school. Because it's hard. I sit across my desk many times every season, I call it. And there's a young man or a young woman sitting there telling me that they're looking for a job. Obviously, we're all struggling to find internists. They all have $200,000 and $300,000 and $400,000 in student loans. It's a very difficult task. Where are all my kids' friends? They're in hedge funds and banking and Wall Street, because it's easier. It doesn't have the value that what all of you do has, but it's just different. I wanted to make one comment about the various models that we were talking about earlier. I remember sitting in a meeting in Tom Frisolak's office with the folks from CareMore. And I remember them telling me a story about alternative ways to solve problems for patients. And Leva told a story about they had a frequent flyer, somebody who had been readmitted to the hospital a dozen times in the past 12 months. So they decided to try something different. They sent a nurse practitioner out to this patient's home. The patient happened to live in Downey. It was a very warm year. Lived in a one-bedroom apartment, and there was no air conditioning. So Leva suggested they put a $400 window air conditioner in this person's apartment. The gentleman, thank God, is still alive, and he hasn't been seen at the hospital since. That's right. It's a great story. There are so many other things that we are all learning to do that we've never done before in our lives. A few thank yous. First of all, thank you to every one of you. It's great to see the room full. It's great kind of you to come out to honor me and to honor Dr. Torrens and UCLA and all the great people here. It really is special. I've been to a lot of these, and I thought this was one of the ones that for me was a wonderful learning experience. These three panelists, I'm going to tell you one more time while I have them and they can't talk, which is a pleasure for me to be able to tell them. These three people all have played a role in any luck or success that I've had. To be able to call upon a competitor or someone else in a business, in any other industry I've ever been involved with, I've not seen the love, the response, the respect come back as I've gotten from these three gentlemen. You guys were dynamite. Thank you. Tamar, I want to add to what Dr. Torrance said. Tamar Karabian has been on the phone with us for months and months and months, taking care of every detail, being kind, offering input, holding up signs telling us to get off the air. You're a wonderful lady, and I think everybody owes you a great thank you for this evening. One of the great things I learned this evening, besides what I learned from the questions you asked and from the panel, is if you ever get asked if you would rather be the moderator or the panelist, be the moderator. A round of applause for Dr. Torrance, who puts this all together for us. Drive home safely, everybody. Thank you for being here.